Hello, everyone, and welcome to today's webinar. This webinar series is brought to you by XL Catlin and the Sullivan Group. Today, it is our pleasure to have with us Dr. Leslie Zunn. He'll be speaking on the topic of the risk of psychiatric patients in the ED. Before we get started, you'll see here that we have done several of these webinar series, and we have archived all of those video broadcasts. You can find those on the Sullivan Group's YouTube channel or by going to our website and looking under webinars. Next slide, please. With that, and you can go one more, just a couple housekeeping announcements before we get started today. If you have any technical issues throughout the broadcast, feel free to chat directly to the organizers. You can also email me. My name is Jenna, and my email address is here if you have any issues, or if you have any ideas or requests for future topics. We're always interested in hearing what you want to learn more about. In the last 5 to 10 minutes of today's session, we will also have a question and answer, but feel free to put your questions at any time during the presentation in the questions or chat box, and we'll address them at the end of today's presentation. All right, so without further ado, I'd like to introduce you to Dr. Zunn. Dr. Zunn, the floor is yours. Thank you so much.
Well, thank you, and I appreciate the time. And just so people know who I am, I have a couple of titles. I am the president of the American Association for Emergency Psychiatry. It's a group of psychiatrists and emergency physicians that advocate for psychiatric patients who use emergency services. I'm the professor and chair of emergency medicine at Chicago Medical School. I'm an attending physician at Mount Sinai Hospital in Chicago, and I work with the Sullivan Group, as you would understand based on this webinar. So I think really before I even get started, we're seeing greater and greater numbers of psychiatric patients who present to emergency departments all over the country. And the latest statistics I saw were about 12% of all ED patients present with a psychiatric disorder or a psychiatric complaint. And we've done a study seeing that there's about another 45% that have some psychiatric overlay or have ruled in for some psychiatric illness. So as much as we want to avoid these patients, or some want to avoid these patients, we're seeing them in greater numbers, and a lot of them board and wait to get admitted or transferred, and that puts us all at risk. So I'm going to be talking about the risk of psychiatric patients in the ED. So the objectives, we're going to look at a couple of high-risk psychiatric patient populations. We're going to look a little about suicide, talk about suicide assessment, leaving against medical advice, elderly patients and their specific issues, a little bit on medical clearance and how that can be a problem or missed. We're going to talk a little bit about circumstances that might increase the risk, both for injury, for suicide while they're in the ED, as well as elopement. And we'll talk about how to reduce this risk. And I bring up a few interesting cases along the way to illustrate the points that I'm trying to make here. So the first case is a 24-year-old male presents not sleeping, cutting at his wrists, seeing shadows. The emergency physician stated the patient was depressed. The emergency physician performs a medical clearance process, leaves the rest of the evaluation to a mental health worker. The mental health worker gave the patient the diagnosis of bipolar disorder and depression. The patient was sent home with a contract for safety and scheduled for an appointment intake in psychiatry in 2 months. So I think there's a few red flags that you can immediately think about, and we'll talk more about it as the case evolves. So the first question is, who does the psychiatric evaluation? I think for many years, the emergency physician said, oh, I don't know anything about how to do that. I wasn't trained in how to do a psych eval. And so they tend to delegate it. And if they have the luxury of in-house psychiatry, great, because that would be a very appropriate person to do a psychiatric evaluation. But what we see instead in many places is that the emergency doc basically delegates it to some lesser personnel, like a mental health worker, someone from community mental health, or even a contracted outside service, and they kind of wash their hands of the responsibility for determining where the patient goes, meaning inpatient, outpatient, those kind of things. And I am a strong believer from a risk standpoint that since they're physically there and they have the greatest training and experience, they should be the ones making the decision if the patient stays or goes. If you have in-house psychiatry or if you're utilizing telepsychiatry, I think you have some insulation and it would be quite appropriate for that person to make the decision. But in the other cases, I'm concerned that they may not communicate their decision, meaning that mental health worker may not communicate that, may not discuss it with the emergency physician, they may not concur, that the emergency physician, as in this case, just said, oh, you do whatever you think is necessary and just wash their hands of the case. So one of the things that we need to look at is how well this psychiatric evaluation is performed, not only who does it, but what is done. So, for most of us in emergency medicine, you can get a feel for what the patient's appearance, behavior, attitude, mood, and affect is just by talking to them and looking at them. But what we don't do that we need to ensure occurs is asking the patient if they want to harm themselves or somebody else. And where this thought came about that you're going to lay the seed in the patient's mind that they never thought about suicide, and if you ask about it, that's what's going to happen, is totally a myth and false. Second is insight and judgment. We need to understand if the patient knows about their illness, if the patient understands why they need to take their medicine, why they need to follow up, will help us determine if the patient needs to be admitted to the hospital or go home. There are also patients that we need to ask about whether they're having hallucinations or delusions. We can't assume that if they're not looking like they're talking to someone else or grabbing at objects in space, that they're not hallucinating. So we need to ask that. And the last thing that we need to ask about is sensorium and intelligence. And this will come to play in a much broader term when we talk about cognitive impairment and patients wanting to sign out against medical advice. Now, the most important thing with sensorium and intelligence is, are they having delirium? And we'll talk more about why that's so important. Now, when we look at suicide assessment, there is no tool that will provide a score and say this patient has a 0.1% chance of killing themselves or 90% chance or whatever. It's not as good. We don't have any tools that are as good today as, the TIMI scale or the Wells criteria or things like that provide us good basis. But rather, suicide assessment, and let me be absolutely crystal clear, this is not suicide screening. This is once they screen in with a risk for suicide, they need a rather extensive suicide risk assessment, putting them into risk categories. High risk, get admitted. Moderate or medium risk, they need a psychiatric consultation today. Or low risk, maybe they can go home with a proper assessment. We need to use good static and dynamic risk factors, as well as taking into consideration protective factors and things like that. And whatever the emergency physician does, whatever decision they come up with, high, medium, or low, they need to do a good job documenting. And I'm sure as risk folks, you're always telling them to do good documentation. And here's another one of those areas where it's really essential that they do good documentation of how they decided which risk category for suicide the patient was in. So as we talk about these risk factors, we talk about high risk. So someone that used a gun or tried to hang themselves or planned it out, or they went somewhere where they wouldn't be found, or they left a suicide note. So those should be a slam dunk, get admitted, no question. Moderate risk, they used some medications, or they took an overdose of something that they abused. They were hoping maybe they'd get discovered, or they called for help. And a suicide note wasn't cleaning up all their affairs, but rather trying to manipulate someone's behavior. And maybe they had some ambivalence about the fact that they didn't succeed. The low risk category are, those that take small number of pills, did it in front of someone else, and they were really happy or felt stupid that they were discovered. This is probably most typified by, that teenager that takes 2 or 3 ampicillin in front of their boyfriends because their boyfriend wanted to break up with them. That patient would not be served by an inpatient admission and just needs some counseling and better ways to deal with their frustrations. So let's talk for a minute about what happens to staff and the patients when somebody comes in with suicide. And this was an interesting study that looked at staff emotions and how it affects patients. Now, this was an inpatient unit, but I do believe that this would still apply to the emergency department. So suicide behavior appears to elicit mostly negative feelings in staff members. And if they don't understand it and handle it properly, that may lead to the patient being discharged prematurely. So it's important to ask staff members to contain and work through any negative feelings they have about suicidal patients. And also, this has been found to be a risk factor for when patients do decide to commit suicide. So now let's talk a little bit about this contracts for safety. I don't know where this came from, but in emergency medicine, it should not ever be used. Now, if I say I'm a therapist or a psychiatrist and I know a patient well and I have a good relationship with them, and I know whether they're serious or not, that probably is appropriate use of a contract for safety, but not in the acute care setting. And as said in the conclusion, never enough. So the contracts for safety are never enough to protect against legal liability and lead to adverse consequences for the patient and the clinician. And I'll tell you, even to this day, I still see them being done, and it just amazes me that the word hasn't got out about the negative problems with this. So here's the follow-up to this patient. The patient was sent home with a contract for safety, scheduled for an appointment for intake and a community mental health 2 months later. The patient returned 2 days later as a DOA. The coroner reported the cause of death as asphyxia due to hanging, had a history of suicide ideation and drug and alcohol abuse. So bad outcome in this case. And what went wrong? The emergency physician relied on a mental health worker and said whatever they decide is fine. There was a failure to diagnose suicide risk. There was a failure to assess suicide. It really wasn't asked and a proper suicide risk assessment being done. So there was failure to take appropriate action, failure to refer to psychiatry, failure to obtain collateral information, because if that mental health worker or if the emergency physician would have inquired to the other family members, they would get more information about him having a rope and a place where he can hang himself in the garage. They didn't involve family, and they never put together a safety plan if they had even thought about sending that patient home. All right. So next case, a psychiatric patient starts screaming at the nurses in ED and states she wants to leave. The patient's restrained, supine in all 4 limbs. And so in this emergency department, they had a couple of psych beds in a psych area, but that day it was full, so they put the patient in a procedure room off to the side. And the patient was basically screaming and yelling, so they were happy to get the patient out of the emergency department. And unfortunately, they left. They allowed her to keep her clothes on as not to agitate her any further, but they did do a weapons screen and didn't find any weapons on her. So let's talk a little bit about, and then we'll talk about what happened with this case. It was not a good outcome. So let's talk about completed suicides in the emergency department. So since 1995, suicide has been ranked in the top 5 by Joint Commission. It's interesting because I did not realize that 8% of all inpatient suicides occur in the ED. Hospitals have to be diligent to identify building and environmental factors that can contribute to the patient's ability to commit suicide, i.e. where we put that patient in the emergency department. And the ED is responsible for the safety of all patients within the hospital confines. So once that patient comes in and says they're suicidal, the hospital, the physician, the staff are all responsible for ensuring that patient's safety while they're there. So, if we look a little bit farther about hospital-related suicides, we see that a lot of them are hanging, jumping off the building. I've seen that, unfortunately. Cutting with a sharp object or overdosing. I've actually seen patients drink a bottle of betadine while they're in the emergency department because they do want to finish off themselves, and that was the only thing available. So when we put a patient who's suicidal in the emergency department, we need to make sure that we looked around for materials that can be weaponized, that or can be used to harm themselves, like the nurse call buttons, bandages, the Curlex, ACE wraps, sheets, restraint belts, plastic bags, elastic tubing, oxygen tubing. We need to remove all those things that are used in the ED. So here's the problem. If we have an ED that is not a psych ED that has, all those proper, or all those things removed and has all those safety factors, including, the ceiling, not having those ceiling tiles they can hang on, the bathroom that doesn't have anything where they can strangle themselves, those kind of things. One, that would be the best. If we don't have a psych area in our ED, then they need to be watched. They need a one-to-one while they're in the department to ensure that they don't harm themselves. And just by the way, restraining them so they don't hurt themselves is not an appropriate use of restraint. And I'm a believer that every patient who comes through the emergency department and visitor and family should all be scanned by a metal detector. So the patient keeps screaming in the procedure room, so the door is closed. The patient has her overalls on and able to get her lighter out of her upper pocket. She uses her lighter to start the curtains on fire. By the way, this is a true story. The curtains falls on her and lights her on fire, and the bed she's on, the cot she's on. She's found to have second and third degree burns over 43% of her body and some smoke inhalation before she's rescued. So what went wrong? Well, just searching the patient for weapons is not adequate. We need to also search the patient for anything that they can use to harm themselves. I think in most emergency departments today, the patient's clothes are removed. Now, there is some debate out there in the psychiatric literature about whether we should remove their clothes and give it back or put them in a gown. I recommend taking their clothes, putting them not just in a regular gown, but somehow identifying that that patient cannot leave. So whatever color differentiates them, or armbands. One location I work uses colored armbands. One used colored gowns, so that everybody knows that patient cannot leave. So what else went wrong? Failure to use proper space for patient care. They used a regular, they used a procedure room rather than a psych area for that patient. They didn't use one-to-one observation for a suicidal patient, and they didn't really properly assess the patient. All they knew that the patient was screaming and disruptive, and all they wanted to do was to get that patient out of the emergency department. Okay, next case. Well, you could see this as an elopement case. A 23-year-old newly diagnosed bipolar disorder is being transported to a psychiatric facility. So again, this is another true story, because the patient gets put on one of those ambulance carts. and they're moving the patient to the ambulance, and on the way, the patient jumps off the cart and runs out the exit door. And the ambulance attendants aren't the fastest and are unable to keep up with the patient. So how do we identify? So we should, when a patient comes in the emergency department with a psychiatric problem, identify who's at risk for elopement. The most important risk for elopement is prior elopement. However, if we don't have that, then we're looking at agitated, schizophrenic, bipolar, and involuntary admissions are most at risk to elope. And we should have one-to-one observation with these patients or video monitoring. Maybe we have some means to restrict entry in and out of that area. We cannot, not a proper use for elopement is to restrain or seclude that patient. Family members may help keep that patient calm or in an area, but they cannot be held responsible for ensuring the patient does not elope. So as we look at assessing risk of elopement, we need to think about especially those patients who say, I don't want to be here, I want to leave. They have a past history of eloping before. They have a history of substance use disorder. They wander out of the ED and security finds them somewhere else or someone else finds them. And also patients with complex social situations where they may be, walking out of the ED to do something else. So how do we prevent that? It would be great to have automatic doors, alarms. We might need to put that patient close to the nursing station. We need to do some risk assessment of them leaving. We ask the family to stay with them. We need one-to-one if we're really concerned about them. And for some, we might need to give them some diversion activities, a TV or a phone or something to try to distract them. Now, children are a little bit different, especially those, and again, I've had cases like this too, autistic, those that are on an autistic spectrum, Asperger's syndrome, mental retardation are the toughest because they don't really understand the risks of leaving. And the older the child, the higher the risk because it's easier for them to get around and get through the system. So these patients may need a sitter, especially if there are, you've done a risk assessment and they're at risk for eloping, they've eloped in the past, those kind of things. You're going to need to have someone standing by or a family member helping with that. But once a patient leaves, you need to have a policy and procedure that is used for those patients, whether you call it Code Green or Code Elope or whatever. Security should be notified immediately and the patient described to them. The unit should be searched, the surrounding hospital area should be searched, and the physician needs to be notified as well. So let's go back to that patient, the 23-year-old newly diagnosed bipolar who ran out because he didn't want to be hospitalized out that exit door. They ran after him, but he was much faster than they were. The patient was found 3 days later. I don't know if anybody knows, in Chicago, they put the two housing buildings or two houses really close together, and there's this alleyway. So 3 days later, he was found sleeping in the alleyway between two buildings, hypothermic. Again, not a great outcome. What went wrong? Failure to initiate a system-wide search shortly after the patient was noted to be missing. So what happened is when the patient ran out that door, it took them a while. So the nurses didn't know about the system-wide policy, and they started looking and walking outside trying to find the patient. What they really should have done was to initiate the code as soon as the patient left the door so that everybody could be on the watch for the patient. So they really didn't follow the hospital policy. They didn't communicate the event to the proper people. And they really, when the patient came in, they should have had a plan for risk assessment of elopement and put in proper procedures for that patient. Okay, next case is an 86-year-old female brought by the family because their mom's not acting right. Okay, so again, this is a true case I know very well. So the patient's brought by ambulance, her son's on the way, she gets to a bed, a cart, she gets put on the cart, and as soon as she sits down, she says, I want to go home. There's nothing wrong with me. I don't know why my son called the paramedics. And there's nobody else to ask. We ask the paramedics and they say, her son just said she wasn't acting right and we were instructed to take her to the hospital. And the son's on the way. So how do we decide that this 86-year-old female who seems kind of with it at the time, can go home or not, to sign out AMA or not? So that really leads to the next question that, of course, competent patients have the right to refuse treatment, but we need to ensure that they have capacity and current capacity. And just because someone says, I drink or do drugs, doesn't mean they're clinically intoxicated at this time and cannot sign out against medical advice. And just because someone might have depression, bipolar, or even schizophrenia, or schizoaffective disorder doesn't de facto mean that they're not competent to make treatment decisions. Now, of course, with psychiatric illnesses, it depends where they're at on the spectrum of their disorder. And we're always told that we need to notify endangered third parties if someone claims they're going to hurt someone else. And I always like to get the family involved with AMA. And I'm not worried about any kind of HIPAA issue if it means I'm doing the best thing for the patient. If the patient's there with family, it's easier. If they give me a phone number of someone, a family member, I will try to call them and see if I can get help to get them to stay. So now, if I can't reach anyone and I need to make the decision fairly soon, what I like to do is rely on one of these short tests of mental status. And as you see here, there's 4 of them that are noted, and it has a number of items. The application, where it's been used before, who does it, is it done by the patient, interviewer, or an expert, how much time it takes. What I recommend to physicians and other providers is you got to do one of these tests, asking them, where are you, what day is it, or what time it is, or what year it is, who's the president, is not adequate and sufficient. And I discourage physicians and providers from using a insensitive test, but rather one that you can score and document and put down on their chart. Their mental status, mini mental state exam score was 0 or 30 or whatever, as a way to demonstrate their cognitive ability. I think is much better than, asking them, where are you, who are you, those things. Now, one test that I like is the clock drawing test. And why do I like that? I like that because the patient does it. It's very quick. And although you can score it, I just do it. Either they do it or they don't. So in this case, I asked the lady to draw a clock and put 8:30. And what you see here is what she did was she did the clock with the numbers on it in that top right-hand corner, but underneath that wrote 8:30. So I felt that she did not have capacity, that she had cognitive impairment, and made her stay. So that would be the best utilization of that clock drawing test. Now, in this case, the 86-year-old female brought by family because her mom's not acting right, she said she feels fine. So in this case, they sent the patient home. She returns the following day with delirium. So we should talk about how we evaluate the patient's mental status as well as delirium. So patients that come to the emergency department, we do a medical clearance test to determine if the presentation today is caused by a medical or psychiatric problem. And the secondary is this issue about transferring the patient. So should we choose to transfer the patient to, say, an inpatient psychiatric facility, does that inpatient psychiatric facility have the resources to care for that patient. So, for instance, there are some inpatient psychiatric facilities that cannot handle patients that need insulin injections or frequent glucose checks, or patients with in wheelchairs or walkers or casts. So, like any other patient, we need to decide if the resource has the capability to care for that patient. Now, this next slide is what I call the Venn diagram of grammar school. And if you look at those three circles in the middle, the role of the emergency department is to figure out, is this a psychiatric problem primarily, a medical problem primarily, or drug intoxication or withdrawal primarily. The problem is it's not always easy to differentiate the three, and they all can tend to coexist. So that's problematic. But the most important thing on this slide is that we cannot miss a patient that presents with delirium. Why? Because there's a high rate of mortality, and we'll talk more about that. So how do we differentiate the patient? We need to do a good history, physical exam. I think mental status testing, as I went through earlier, maybe lab testing for certain patients, and those patients that have an obvious medical etiology will probably need testing are those with exposure to toxins or drugs or withdrawal, those that present with a new psychiatric presentation that does not have a psychiatric history, abnormal vital signs, delirium, that's going in and out of being attentive, being conscious, those kind of things. A focal new cognitive deficit or a new focal neurologic deficit. And sometimes these patients aren't clear and need to be admitted so that we can better ascertain what the etiology is. Now, if we look at geriatric psych patients, we see that they may present with a psychiatric presentation, but may turn out to be an infection, or may have fallen down and have a subdural, or may have a vascular problem, including cardiac ischemia and MI can cause behavior changes. So these are the kind of labs that we would do to try to assess in a Gero-Psych patient what the etiology might be. And we tend to look frequently at medication-related change in behavior, especially if they're on new meds or change in dose. We're looking at thyroid abnormalities, again, fairly frequently as well. So the prevalence of mental illness in older adults admitted from an emergency department is fairly high. So as we see in this study, there was about 1,000 patients who were screened. Believe it or not, only a third had no mental illness. 50% that were over age 70 had some cognitive impairment. 27% presented with delirium. Between 8 and 32% were depressed, some agitated, some hallucinating. So this slide really tells me why identifying delirium is so important in the elderly population, because we know it's fairly frequent, and we know that it's frequently missed, that we don't do a great detection. And if we miss it, the mortality rate is 36%. And if we catch it, the mortality rate is then 10%. So there are tools that can be used in the emergency department to identify delirium. And the confusion assessment method is one that's frequently used and one that should be used to rule that out. There are many predisposing etiologies to delirium and precipitating. So patients that are older, who have dementia, on lots of medications, if they're already somewhat cognitively impaired, or if they have a psychiatric illness. So a lot of things present as delirium, infections like UTIs and pneumonia, thyroid problems, new strokes, seizures, MI, congestive failure, just about anything that we can think of. Even iatrogenic, like putting in a catheter or restraining the patient, can make them go into a delirium. So the thing that's, again, important is they can have both a dementia and delirium. Delirium is more associated with abnormal vital signs. Patients present commonly, elderly patients present commonly with depression, and we need to look at, they may present with other symptoms, feeling fatigued or loss of energy or malaise. Elderly patients don't tend to admit their suicidality, but there is a bimodal distribution of suicide, and it is high again in the elderly patients. If they're seeing things or hearing things that aren't there, we need to think about medication-related psychosis. And although there is frequently substance use disorder in this patient population, but there's a high denial rate. So now we're back to that 86-year-old female brought by the family because she's not acting right. She says she feels fine. She's ready to go home. She's sent home. She returns to the ED comatose the following day. She was found to have delirium from neurosepsis, and she did poorly. So what went wrong? Failure to identify that patient who has cognitive impairment. So if the physician had done a good cognitive assessment, they would have seen that the patient was cognitively impaired, even though they knew where they were at right now. They didn't talk to the family. The family would have said, sometimes my mom seems right and sometimes she seems off. So there was a failure to diagnose delirium and, of course, a failure to admit the patient. Next case is a 36-year-old male who presents to the emergency department with, taking a little Ativan and drinking last night. He feels depressed, but he decides he didn't want to wait any longer to be seen, and he wants to leave the ED. And the nurse at triage ordered a urine drug screen and alcohol level, but it's not back yet. So the question is, can we let this patient go against medical advice? Well, so there's no great test for determining capacity to consent. And there's a couple of tools out there like this MacArthur test, but it takes a long time to do. I don't think I could get the patient to sit 20 minutes to talk to me about understanding, appreciation, reasoning, and expression of choice. And that tool was really designed for clinical trials. And it's interesting that there is no definitive test for capacity. And quote, there are no formal practice guidelines from professional societies for the assessment of patients' capacity to consent. And Applebaum would really be considered the expert in this area. But what I say is we need to document meticulously the patient's capacity for decision-making, risks and management, risks and benefits of treatment or admission or whatever, that this was discussed with the patient. We probably should do a read back as well to confirm that the patient's understanding. So let's talk a little bit about, well, we did a drug screen on them, and what does that mean? And should we wait for it or not? The problem is that most drugs or metabolites are positive for 1 to 3 days. Well, if we look at marijuana in the urine in a chronic user, if I stop today, it can still be positive 42 days from now. So that doesn't tell me they're clinically intoxicated or clinically impaired from the substance. And the American College of Emergency Physicians says that routine urine tox screens for wake alert cooperative patients does not affect ED management. And pretty much the same thing for blood alcohol levels, but rather we should use cognitive ability. So to me, we need to assess their clinical sobriety, not based on a lab test. We know that drug screens are limited. They don't test for all drugs of abuse. There's interference from medications and other substances, and there are some false negatives and positives. But rather, what we should be doing, and the emergency physician should be doing, an evaluation of intoxication. So clinical intoxication is not a lab test. It's a clinical diagnosis based on the patient's level of consciousness, their speech, their cognitive function, and assessment of coordination. Do they have nystagmus? Is their speech slurred? Do they have normal gait or not? So now we're back to this 36-year-old male who presents to the emergency department. He ingested lorazepam and drank last night. He doesn't want to be seen. The patient's waiting. Well, the labs aren't done yet. The nurse has them sign out AMA, and the patient drove the wrong way on the highway and was brought back to the ED from the trauma scene. Not good. So the first thing is, in that institution, the nurses were letting the patient sign out AMA. Not a good idea. And if that's going on in your institution, it really should be a physician who gets involved. Anytime a patient wants to leave against medical advice, they need to get pulled over from wherever they're at and do an assessment of the patient. They need to do some proper assessments of the patient's capacity. We cannot rely on waiting for a urine drug screen or alcohol level, and I wouldn't rely on that. Matter of fact, I don't think that there's only one indication to get a urine drug screen or blood alcohol level on a patient in the emergency department. That doesn't back us into a corner, which is altered mental status without an obvious etiology. If we have a patient that's brought by the paramedics with a bottle of vodka next to them, they smell like alcohol, they admit to drinking, they have some incoordination, I don't need an alcohol level to tell me they're clinically intoxicated from alcohol. But if they came in and they're not acting right and I have no idea why, then I think alcohol and urine drug screen's appropriate. And if the patient wants to leave and the physician is not immediately available, I think security needs to stop them from leaving until they can be properly evaluated. I didn't say restrain, I said properly, try to convince them to stay. Next case is actually was in the news a few weeks ago or months ago. Ann met a South Carolina hospital, had to pay $1.3 million for improper treatment of ED psych patients. There were 36 psych patients with unstable psychiatric conditions who stayed in the ED without proper and appropriate psychiatric treatment. So what was happening is they were deciding, for not the best reasons, I believe financial, that the patient would stay in the ED and wouldn't even involve the on-call psychiatrist to help manage those cases. So instead of being admitted to their psych unit, the patients were involuntarily committed and kept in the ED until a bed for an unfunded patient was available for days to weeks. So EMTALA does apply to psychiatric patients. There are some questions about CMS considers the ED physicians qualified to perform a psychiatric portion of mental status. I personally think they should, and there's no question in my mind that they have the ability to do that. And if you're in a state that says we take all comers to the state psychiatric facility, you cannot differentiate unfunded patients and send them to the state and delay their care when you have a bed available in your own institution. Illinois is like that. There are state psychiatric hospitals, and a patient cannot sit in the emergency department waiting for one of those beds if there is an inpatient bed available in your institution. Compliance with state commitment process, so whether they get committed or not under state law is unrelated to the EMTALA issue. Either they need to be admitted or they don't, and if they need to be admitted and you have beds, you cannot determine it based on funding. But it happened fairly recently. It was done that way. So we kind of talked about payment. Patients with emergency medical conditions who need psychiatric admissions often cannot get beds in a timely fashion. There are certain state civil commitment laws that conflict with the federal EMTALA requirement. And so, of course, the federal EMTALA law would trump the state civil commitment issue. So, in order to leave some time for questions, I want to kind of wrap this up. So, So suicidal patients not only need a suicide screen, but also need a risk assessment of whether they're high risk, moderate risk, or low risk for completing a suicide. That we need to help our staff who have some attitude issues with suicidal patients, be getting in touch with those issues, understanding why they have some concerns or problems with that suicidal patient, and dealing with it. As we bring psychiatric patients into our emergency department, we need to make sure wherever we put them that it is a safe environment. We cannot be putting a suicidal psych patient in a regular medical bed where the head wall has oxygen tubing and there's betadine and all sorts of other things there, unless you're going to put someone there to watch them one-to-one. A hospital personnel, they really should go to the appropriate space where they cannot harm themselves. When a psych patient comes in, we need to do a proper elopement assessment to determine their risk for elopement and take appropriate mechanisms to reduce that risk of elopement. And the same would be true even when they're being transported out of the institution. We need to make sure that while they're being transported, we've done our responsibility to keep them safe and not running away. Emergency physicians have responsibility for determining who needs to be admitted and who can go home, and they cannot delegate that to a crisis worker, whether it be outside contracted or their own. They have a responsibility to determine, like any other patient, whether the patient needs to be admitted or go home. They can use that crisis worker's help in the assessment, but it should not be that mental health worker's decision alone. And when we have patients who want to leave AMA, a couple things. One is we need to assess whether they're clinically intoxicated or not, that the physician should be involved in assessing the patient's capacity and ability to leave against medical advice. It should not be done by a nurse, and there should be a proper mechanism to assess them. And they should be held until the physician can get there, if possible. Some of that may be a judgment call, but if possible, we want to get the physician involved, who should do a proper capacity assessment. So this is the last slide, so then I'll take questions. I put on the left-hand side my contact information, email, and cell phone. And on the right-hand side, I just want to make everyone aware of the fact that we have my organization, the American Association for Emergency Psychiatry, has a annual conference on behavioral emergencies. It'll be in December again, and it'll either be in Vegas or in Phoenix. And all we do for 2 days is talk about behavioral emergencies, and we have a scientific session, and it really is a group of emergency physicians and psychiatrists that get together to discuss this for 2 days or so. So with that, I want to thank everyone for attending the webinar, and I am happy to take questions.
Wonderful. Thank you so much, Dr. Zahn, for all of this great information. Before we address these questions, just a reminder that you can drop your questions in the question or chat box, and we'll try to take the time to answer them all. If we don't get to your question, we'll follow up with you after the event. First question for you, Dr. Zahn, is who is suitable to act as the one-to-one supervisor for a psych patient in a non-psych ED?
If I'm to understand the question correctly, so who can do one-to-one observation for the patient? So that could be anyone that's properly trained in, one, observing the patient, and two, they have some training in CPI or verbal de-escalation or something in case the patient gets agitated or wants to leave or has some concerns. But we really need an appropriate person. It might be a sitter that has additional training We don't expect them to provide medical care or therapy, but really just observe the patient, and should there be an issue, they know how to properly respond to them.
Great, thank you. The next question is, are standalone mental health facilities required to accept uninsured patients referred to them from an ED, especially if they require admission for suicidal risk?
Okay, so independent psychiatric hospitals, if they're a Medicare provider, they have to take patients that are suitable for their institution if they have the capacity and the ability to care for that patient. And that's what's available at the time. Yes, there's an EMTALA obligation to take that patient.
Great. And then the next question in relation, can you comment on the risks of holding a patient in the ED environment for many hours or days as compared to a more rapid transfer to a psych inpatient bed?
Oh, yes. Oh, that. So there's a number of problems with boarding psychiatric patients in emergency departments. So we can talk first about the risk. So while they're there, if it's not an emergency department that's designed for psychiatric patients or has a psych area or psych ED, so we're always worried about them injuring themselves, injuring other people, eloping from that area. Second concern I have is usually when they're sitting in the emergency department, they're not receiving treatment. Usually we tend to over-sedate them and leave them in the corner. I don't think that is good medical care nor fair to the patient. So, what's best, like any other patient, is that we should be getting that patient transferred as soon as possible. And before they get transferred, we're treating them for their condition they came in for. So we never let a pneumonia patient sit there with pneumonia until we can get them a bed somewhere. We're going to treat them in the ED. I think that we have to treat those psychiatric patients in the ED while they're waiting for a psychiatric bed. I want to go a little bit farther with that because I don't understand why emergency physicians are so reluctant to treat patients with psychoactive meds. We treat patients with a lot more dangerous medications than antidepressants and antipsychotics. So I'm really surprised, especially when we know what the patient was taking before and they stopped taking it. There's no reason we can't restart their meds. So yes, we need to treat those patients like any other patient, get them treated and transferred as soon as possible.
Great. And this sounds like a clarification question. What is the competency or training required for sitters in order to sit with these kind of patients?
Each hospital will determine what competencies they expect, but from my perspective, they all need to have really two basic skills. One, the ability to continually watch the patient and ensure that they will not harm themselves or anyone else. And the second is that when something is happening that may identify them as getting agitated, they need to, one, properly identify this agitated condition, communicate that to the primary nurse, and if the patient approaches them feeling agitated, that they know how to de-escalate that situation. So it's really one, proper observation of the patient, and two, the ability to de-escalate problems that the patient's presenting with. I mean, should they be getting more agitated and so to speak, reaching out or approaching this sitter, the sitter knows how to de-escalate the situation and not make it any worse.
Mm-hmm. Okay. In general, do you think that the ED triage nurses would benefit from more specific training in the triage of psych patients?
Well, I happen to be a believer that all emergency department staff, nurses, physicians, techs, all need more training in behavioral emergencies. It's really a problem that that everyone is not more adept. So if we look at 12% of our patient population is a psychiatric patient, and at least for emergency physicians, they do not have to do any time in a psychiatric facility, any time on a psychiatric unit or a psych ED. So that is really unfortunate that they don't get adequate and sufficient training. I think the nurses actually get better training, but I think we all could use more training. And just a little plug, at our conference this year, we had a pre-conference session sponsored by the Coalition for Psychiatric Emergencies. ENA and ASAP are all members of this coalition, teaching emergency physicians emergency psychiatry and teaching psychiatrists emergency medicine for the first day. So I really think we have a ways to go, and we really need to teach our staff. The other thing I want to digress, one other thing is that every staff member that works in an emergency department has to have training to deal with agitated patients, how to address it, how to do verbal de-escalation, whether you use CPI training or any other training. There's different training programs, but every staff member should know how to deal with the agitated patient and should understand some concept about de-escalating the situation.
Great, thank you. In addition to medications, do you agree that boarded patients should also start receiving therapy in order to alleviate their BH symptoms, or would that worsen their symptoms?
Well, I think it'd be, well, okay. So I think it would be great that we initiate this. If a patient spends a couple days in the emergency department, they should be getting the same level of care that they're getting on an inpatient unit. So that would be medication therapy or some other treatment, or that patient should go to a psych obs unit, actually starting one up in Chicago. Really, we should do our best to provide the same level of care. Now, I understand in some facilities they have very limited resources, and so they may not have all those abilities, but they might be able to use telepsychiatry. They may have some folks from the inpatient unit or community that can come and provide some services. We're also looking at bringing peer mentors, peer counselors into our psych obs unit to assist in some of that counseling. So yes, that would be great while they're boarding in the ED to provide additional therapy. I'm just not sure that very many EDs are doing that right now.
Okay, thank you. We'll end with this last question here. Could you outline some components that an on-site risk assessment, let me rephrase this. Could you briefly outline the components of an on-site risk assessment of the care of the ED psych patient? What should a risk manager or insurer look for?
Oh, I'm not sure I can answer that in 2 minutes or less, but let me try. So I think there's a couple of issues in here. So one, we want to know how they do their psych assessments. We want to know where they put that psych patient, how they protect that patient, how they prevent further injury, elopement, and violence. We want to know what resources and what processes that patient goes through for not only their medical assessment, but their psychiatric assessment, and what resources are used to make that decision. So really what I'm saying kind of in a nutshell from a risk standpoint is we need to make sure that the patient remains safe while they're in the department, they don't hurt themselves or escalate, and that we've done the proper assessment. And then once we've assessed that patient and decided whether they need to be admitted, what do we do if we don't have a bed, and how do we best manage that patient to reduce the risk of, again, that same safety issue, risk of hurting themselves while they're waiting for a bed, a risk of elopement, a risk of actually deteriorating psychiatric condition. So it's a lot. It's fairly involved. And the other thing that I would also suggest the staff do is do some kind of mock review. Have a patient say they're suicidal or agitated and see what the staff do and how they respond, to see whether they have the proper skills and abilities and use appropriate risk management techniques when they have a mock patient come in.
Okay, great. To respect everyone's time, we're going to end it there for the day. We did receive some more specific questions, so we'll pass those along to Dr. Zun and follow up on those after the webinar. But at this point, I'd like to thank everyone for logging into today's webinar. We will make this video recording available, and we'll email this out early next week if you'd like to share this program with your colleagues. And stay tuned for our next in the webinar series. We will send out an email invitation here in the next month or two. So thank you, Dr. Zun, for all of the great information, and everyone have a wonderful weekend.
Thank you so much.